Hello, my name is Mini Chakiath Varghese. I am one of the DNP students at the Brandman University and I am presenting on cystic fibrosis. Some of the facts about the cystic fibrosis. It is the most common life-shortening autosomal recessive disease among Caucasian populations with a frequency of 1 in 2000 to 3000 live births. The median predicted survival for CF patients in the United States is 39.3 years. It is an inherited disease of the mucus and sweat glands. It most often affects Caucasians who are Ashkenazi Jews. It only occurs when both parents are carriers, which gives their children a 1 in 4 chance of contracting the disease. The most current statistical data, according to the Cystic Fibrosis Foundation, more than 30,000 people are living with cystic fibrosis. Approximately 1,000 new cases of CF are diagnosed each year. More than 75% of people with CF are diagnosed by the age of 2. More than half of the CF population is 18 or older. Nearly 10 million people in the United States are CF carriers. Now, how a person gets the cystic fibrosis? To have CF, you must get one copy of the CF gene from each parent. That means that each parent must be a carrier of the CF gene. When two people who are carriers have a child, there is a 25% chance of having a child with CF. When one parent has CF and one parent is a carrier, then there is a 50% chance having a child with CF. The cystic fibrosis transmembrane conductance regulator provides instructions for making CFTR protein, which functions as channel across the membranes of the cells to produce mucus, sweat, saliva, tears, and digestive enzymes. The channel transports negatively charged particles called chloride ions into and out of the cells, helps control the movement of the water in tissues, which is necessary for the production of thin, freely flowing mucus. Mucus lubricates and protects the lining of the airways, digestive system, reproductive system, and other organs and tissues. In normal cases, the normal CFTR channel moves chloride ions into the extracellular fluid as seen in the picture. But in case of cystic fibrosis, the mutant CFTR channel does not move chloride ions, causing sticky mucus to build up on the cellular surface. A person diagnosed with CF can have different signs and symptoms. They can have sinus problems, nose polyps, salty sweat, trouble breathing, frequent lung infections, enlarged heart, gallstones, trouble digesting food, abnormal pancreas function, and fatty bowel movements. What will be the subjective data? Well, neonates may present with failure to pass meconium or bilious vomiting and progressive abdominal distension. Patients younger than 1 year may present with wheezing, coughing, and or recurrent respiratory infections and pneumonia. GI tract presentations are in the form of steatorrhea, failure to thrive, or both. Patients diagnosed later in childhood or in adulthood are more likely to present with poorly formed large, bulky, foul-smelling, greasy stools that float in water. Patients may present with a history of jaundice or gastrointestinal tract bleeding. Recurrent cough, which can be dry and hacking at the beginning and can produce later mucus. Dyspnea on exertion, history of chest pain, recurrent sinusitis, nasal polyps and hemoptysis may also occur. Undescended testicles or hydrocele in boys, absence of the vas deferens, male infertility, amenorrhea may also occur in females. Now let's move on to the objective data. Physical examination might show these findings. Nose examination, rhinitis or nasal polyps. Pulmonary system findings, tachypnea, respiratory distress with retractions, wheeze or crackles, cough, increased antero-posterior diameter of chest, clubbing, cyanosis, hyperresonant chest upon percussion. GI tract findings, abdominal distension, hepatosplenomegaly, rectal prolapse, dry skin due to vitamin A deficiency, cholosis due to vitamin B complex deficiency. Examination of other systems could show scoliosis, kyphosis, swelling of submandibular gland, aquagenic wrinkling of the palms. Atypical manifestations are bilateral absence of the vas deferens in men and polyuria and polyphagia in an infant. Cystic fibrosis can be classified into two forms of CF. One is called classic CF, in which patients demonstrates clinical disease in pancreas, upper and lower respiratory tract, and male reproductive tract and has elevated sweat chloride of more or equal to 60 millimoles per liter. Non-classic CF is about 2% of patients fulfill diagnostic criteria for CF but have a normal or intermediate sweat chloride result. The complications of CF are nasal polyps, persistent sinusitis, bronchiectasis, atelectasis, pneumothorax, hemoptysis, hypertrophic pulmonary osteoarthropathy, gastroesophageal reflux, pulmonary hypertension, cor pulmonale, end-stage lung disease, pancreatitis, cystic fibrosis related diabetes mellitus, meconium ileus, distal intestinal obstruction syndrome, rectal prolapse, vitamin deficiency, fatty liver, focal biliary cirrhosis, portal hypertension, liver failure, cholecystitis and cholelithiasis, rickets, and osteoporosis. The differential diagnosis: acute sinusitis, bronchiolitis, failure to thrive, pediatric asthma, pediatric celiac disease, primary ciliary dyskinesia. The workup for cystic fibrosis includes either positive genetic testing or positive sweat chloride test finding of more or equal to 60 milliequal per liter and one of the followings, which are typical chronic obstructive pulmonary disease, documented exocrine pancreatic insufficiency, and positive family history. Screening: prenatal screening, Prenatal genetic sampling by amniocentesis and chorionic villus can show CF in the fetus. Neonatal screening. All newborns are generally screened to see whether they have faulty CF genes. The blood is also tested to tell if their pancreas, which aids digestion, is working properly. Postnatal, congenital bilateral absence of vas deferens, mutation analysis performed on buccal or on blood cells using a Guthrie card, sweat test, cystic fibrosis carrier testing, genetic test of blood or saliva can detect faulty gene. What are the diagnostic tests for CF? Sweat test, chest radiography, abdominal radiography, chest CT scanning, ultrasonography, lung clearance index, hyperpolarized gas lung MRI, genotyping, pulmonary function testing, contrast barium enema. Treatment. Since cystic fibrosis has no cure, there are treatment goals which are as follows. Prevent and control lung infections. Loosen and remove thick, sticky mucus from the lungs. Prevent or treat blockages in the intestine. Assure sufficient nutrition and prevent dehydration. Specific treatment methods are available for treating lung problems. Chest physical therapy, aerobic exercise that forces hard breathing, pulmonary rehabilitation, antibiotics, anti-inflammatory medicines and bronchodilators, lung transplant. The American Cystic Fibrosis Foundation has specific clinical practice guidelines for preschoolers with increased respiratory symptoms, which are shown in this slide. There are also specific clinical practice guidelines for routine monitoring and nutritional care of preschoolers with cystic fibrosis, which are given in this slide. There is also specific clinical practice guideline for behavioral assessment and management of meal times, which are also given in this slide. There are specific clinical practice guidelines for assessing cystic fibrosis impacts, which are rapid physical growth, pubertal changes, sexual development, development of personal identity, autonomic independence, development of interpersonal relationship, planning for the future, and risk-taking behavior. Patients with CF can have potential impact in all these areas, which needs to be monitored and followed up. Different management methods of cystic fibrosis are use of mucus thinners, oxygen therapy, bronchodilator use, and nebulizer care. Again, there is vest therapy, antibiotics as needed, CFTR modulator therapies, vascular access devices such as PICCs and POTS, lung transplantation, nasal polyp removal, endoscopy and lavage, feeding tube and bowel surgeries, partnerships for sustaining daily care. Now, what is the self-management, or what can we teach our patients? we need to tell them to pay attention to nutrition and fluid intake, use of antacids as and when needed, supplementation of high calorie nutrition, special fat soluble vitamins, extra fiber to prevent intestinal blockage, extra salt especially during hot weather or before exercising, adequate water during hot weather, keeping immunizations up to date, regular exercise to help loosen mucus in the airways, eliminating smoke, and encouraging hand washing. How can we prevent cystic fibrosis? If anyone or the partner has close relatives with cystic fibrosis, both may want to undergo genetic testing before having children. If a person is already pregnant and the genetic test shows that the baby may be at risk of cystic fibrosis, the doctor can conduct additional tests on developing child. But remember, before taking genetic testing, consult with a genetic counselor about the psychological impact the test results might carry. These are certain references that I used for my presentation. These are some more of my references for this presentation. I want to thank you for watching my presentation and hope you gained some knowledge about cystic fibrosis. Thank you once again.